So a little bit about the Prexion machine. We can kind of look at the time balance and see if that's something that we really want to get into in any kind of depth. But we're able to see some things and show patients things that I just never could do with conventional radiography, including if they've got some sinus disease. We can even show them what that looks like using the scanner. This shows the mandibular midline artery. Good to know where that is. I had an incident with this, and I'll talk about it later, which was life-threatening, and the patient did fine, but you got to stay away from this guy. So it's good to know where that is when you're planning an anterior implant. Let's look at some more. This is a case presentation. This is a 59-year-old professional Caucasian male, negligent dental care as a young person, went 10 years before seeing a dentist, again because of dental phobia, bad experiences as a child. Y'all hear this all the time. This guy's had multiple endo procedures, several endo failures, including fractures. He's had 3 implants, and the CBCT scan that I'm going to show you in a minute will show you some other findings. Here are the implants that were done in the upper left quadrant. This is number 13. Number 14. This is me, by the way. Okay? And so we take the scan, and we can see what my former partner did the bone graft. Dr. Domang went in and placed it. It looks like an AnyRidge here, and then a taper screw in here. And then we're looking at the scan, and what we start noticing is, well, then the other thing is on my birthday this year, this tooth split, root canal tooth split. So we took this out, grafted it, and I just didn't put a tooth in there. So well, it doesn't really show. And I had a patient one day that said, "Are you missing a tooth?" I said, "Yeah." So I got home. Jermaine goes, "You get your mouth fixed." So anyway, I got a temporary in there right now. So in looking at the scan, you can see this is a socket preservation graft done with fusion bone binder, freeze-dried bone. We let it stay in there for a good 6 months. We could have gone in at 2 or 3, but we kind of forgot about it. Like Daddy used to say, never buy your car from a car mechanic. We don't take care of ourselves as well as we should, some of us dentists. So here we're analyzing this thing, and if we want to use a BioHorizon implant, we use Prexion software, pick out the one that would go in that spot, or we can look at using an AnyRidge implant. Those are the two main systems that we use in the practice. So we're looking at this scan, and look at this. So we start noticing this. This is number my right side, number 3. Here's the BioHorizon implant that Dr. Domang did for me. And then look at this deal up here. And then look at this. And I'm telling you, I see this every day. Every day. And it doesn't show up on regular x-rays like it does on these scans. It's the scariest thing in the world. I mean, and Kathy, I'm sure you see it all the time. I mean by the jillions. And I don't know if they're root fractures. A lot of them are root fractures. A lot of them just couldn't find the 4th canal or whatever it is. But it's uncanny the number of endo failures that I've seen since we started doing this, including my own mouth, And, I'm not too happy about it, but that's the reality of it. And I think what I'm going to do here is, along those lines, let's look at some of this stuff. And I'm going to kind of fly through this because this is a lot about the machine. I don't really want to talk about it that much as I want to talk about what we're seeing, as much as I want you to see what we're seeing with the machine. So it's accurate, it's powerful software, you can network it through the whole office, so we have access to it in every operatory. It's great for assessing bone dimensions, accurate assessment of your vital structures, detecting pathology that is a lot of time is not seen with conventional radiography. I mean, the number of cases where this tooth is really bothering, it's like, I think I maybe see something on the x-ray, not real sure, take a CT, big old lesion, and it just doesn't show up in 2D radiography. Preoperative selection of implants for every case. We can produce a 3D animated video for patient education, which is pretty neat. And it's valuable for assessing impacted canine supernumerary teeth. It's saved in a DICOM format, so it's unlike, I guess, Sorona, that you got to have a Galileo, you got to have a Serac. This is pretty, it's kind of a open source? Yeah, open source. It's a great tool for patient education. It's an excellent system for fabricating surgical guides, but I'll tell you right now, I've done some surgical guides, and I don't do them very often. It's a lot of trouble. And it's all neat stuff, and it makes for a great slide presentation, but I just don't do them that often. And the labs are making a lot of money. Everybody's got their hand in the pot for this thing. And I'll tell you what happened. My partner probably 6 months ago, had a guide made. It cost about $700. He put it in and he drilled all the holes. And when he got done, 2 of them went out of the lingual plate. You know, and I mean, he's a good clinician. I don't know what happened, but it was not a good day. Not a good day. So we look at these in all the operatories, 3D animations. You know, we get these great images. I'm going to kind of run through this fast because I know y'all have seen this already. But what I really want you to see is some of the stuff that we're seeing in practice. And this is something that it's good to know about, you know, because if you're anticipating doing anything in here, if somebody's got some sinus disease, they need to go see their ENT and get that cleared up. As I said before, you know, it's really important to know where this is, because if you violate this, you can cause a hemorrhage that could block off an airway and cause a patient to get in some real distress. So good to know where that is. So here's an example of a case, 60-year-old male, unstable lower denture. He wants to consider implants in the mandible to support his lower denture. Questionable ridge width, and the CT revealed a compromised ridge width. So I don't do a lot of mini implants, but this is a case where we did, because we didn't have much of a choice. And you don't, you know, this guy doesn't look like he would have a mandible that thin, but the truth of the matter is we can't use this. You know, this is not going to fit. This will. And so as far as treatment options go, real cost conscious and all these other kind of things, it's like, well, look, you know, you got these cortices that are almost touching each other. The only thing that we can use are mini implants in a case like this. Like I said, I don't do a lot of them. I did 4 this week. I probably hadn't done a mini implant, I don't know, 4 or 5 months. It's been a long time, because I believe in the real thing. But for this case right here, which is working out real well, I think that was a treatment of choice. You know, a lot of times the dentist will say, all you got to do is get in there and just plane this down. We can do all on 4, you know, clear choice, all on 4. We're just going to plane that down until the bone gets thick, and then we're going to put our implants in. Well, this bone doesn't get thick down here. It stays thin. And so it's incredible how many of these abnormalities that you discover when you start looking at these scans. His 77-year-old female, unstable lower denture, wants to have implants in the mandible to support the lower denture. Ridge width looks favorable for conventional root forms, and the CT-CB reveals optimal width for placement of conventional single or 2-stage implants. So with this deal, we're able to go ahead and select, based on the amount of available width, we can go ahead and select the length as well as the width of the implants that we're contemplating using in the back and the front. So we kind of, I knew today was going to be a problem when I got in my new car and the engine fault control light goes on. I don't even know what that means. What is that? Does anybody know what that means? Engine fault control? Gas cap? Really? Thank you, man. I was nervous all the way here. I don't know where Harahan is, and I don't even know if I'm going to be able to get there. So in developing a case like this, we're able to look at the scan, determine the amount of bone width, determine the amount of height, and once again, not done with a guide. In the maxilla, this bone is not very dense. In those cases, I like to splint these together. I really don't like to do bars, but there are cases where if we're dealing with grafted bone, D4 bone, then I do like to tie them together. So here we have locator attachments on this bar, locator attachments on this bar right here. Here is a 20-something-year-old female, number 7 and 10, were replaced with mini implants. This was done flapless, not by me, by somebody else. And so the little girl comes in and said, this one stays sore. He's done it 2 or 3 times. So I said, well, you know, we ought to take a CAT scan and see what's going on. And so this one, number 7, look where the implant was placed. This is all the bone she has. So the implant is placed, it's in the palatal tissue, basically, with this ridge lap right here. So how this guy didn't get sued over this deal, I don't know, but it came close. Here's the left side, which is a little bit more stable. But it's kind of one of those things, you know, I talked to the mom, I said, you know, we can do all this bone augmentation and build the ridge up and this and that and this and that and this and that. And I said, on the other hand, we can do some conservative preps, which I don't like to do, but, you know, she was so burnt out and so upset and frustrated, you know, that we did the more aggressive thing, which used to be what we call conventional dentistry, and just restored it with 2-3 inch bridges. Now that I've had more experience with the sonic well system, which we'll talk about in a little while, you know, I might have gone back and grafted those and waited, but I can tell you they were waving the red flag. I mean, she was really wanted to get into something soon, and so we opted for what we used to all consider to be standard of care. So 38-year-old female had implants attempted 12 years ago. They abandoned the procedure. First phase of treatment. Winston Deal is a friend of mine, he's a periodontist. She was like 20 years old. They flapped her, said, you don't have enough bone. Closed her back up. She left crying. She wound up with 2 Maryland bridges. Fast forward 20 years later, she comes in. She's a teacher at a local high school. And I'll show you her scan in a minute. But basically what we did was we grafted the insufficient sites, number 7 and number 10, with particulate bone using the sonic weld membranes over and left the graft in for a good 8 to 10 months. So this is what she presented with. And what you see in here is this is the number 7 site pre-op. It's number 10 site pre-op. This is what we were able to develop using just particulate bone and the sonic weld system without taking chin, without taking ramus. I've done that stuff before. There's too much morbidity associated with it. And it's a headache. And you go into the chin and you do all this stuff and you get the bone out. By the time you get done, it's like, man, there's not that much there. That was a lot of trouble. And so nowadays with the sonic weld and some of the things that are out there, we're able to develop these sites predictably. And so you have to look real hard here, but what you see here is, here's after the area is flapped up. You can see the invagination up in these areas above 7 and 10. Here we've got our graft material placed with the sonic weld. You can't see it because the membranes are clear. It's like a clear acetate. And what it does is it stays stiff, so it prevents the lip pressure from causing that bone graft to resorb over time. And so then we've placed PRF over that, sutured it up. And so here we are before, this is after. Here we are placing some smaller diameter implants. Custom abutments in both spots, lateral incisor, final restorations. So this is before, after. We still have to go back and do some work here. And she's even thinking about doing some veneers and that. But the big deal was to get her out of these Maryland bridges that kept falling out. She didn't want to have fixed crown and bridge in the front. 40-year-old male missing his central incisors. You know, only on the CT scan are we going to be able to determine if we really have enough width here, and also can we really get 2 in there. Because some of the ortho cases that I've seen, and I'm sure you have too, where the roots are converging and they're already taking the patient out of braces, and then you're trying to squeak these things in there. Sometimes the best thing to do is just to put 1 in and then cantilever a tooth off the side rather than getting too close to these adjacent teeth. But with a scan, you can determine ahead of time if you really do have enough room to work with. Here's Kathy. This is the case. This is one of the ones that comes to mind. This lady comes in one day and she goes, "Your implant is hurting when I chew." And it's like, man, I don't think so. You know, and I'm banging on it and checking the bite and all that. And I said, you know, this looks a little weird down here. Let's just do a scan. You know, not really expecting anything. Look at this. This is the same tooth. So this doesn't look that impressive. Boy, that does. And so then you go back and look at the X-ray. You said, well, yeah, you know, there is something going on there, but this kind of confirms that this tooth's got to go. 60-year-old female interested in having lower posterior teeth for implants. X-rays look relatively normal, I guess. But what we're seeing on the scan is, look at this. There's some kind of bony dysplasia going on in this area that really wasn't obvious, and really not obvious on the X-ray at all. You know, I sent in an oral surgeon. He goes, man, you know, maybe we ought to watch it. She wound up not having any treatment done because he had talked about watching it over time and then going back and cleaning this out and grafting it, and with the risk of nerve injury and all these other things. So she wound up not having anything done. But you know, thank goodness when we looked at this crappy Panorex, you know, that we had something a little bit more definitive to look at to try and determine, you know, if we had enough bone to work with, and then we find something like this lingering below. And so, you know, with the scan, I've seen a lot more bone pathology in the last couple of years than I've seen since I started practice. This is a patient referred for removal of number 3, possible implant placement at the same time or after the socket heals. We take the CT scan, and it's like bam, bam. You know, we're seeing other stuff. And so instead of discussing just this, you know, I sent this lady to the endodontist to have these other teeth treated. This is a patient that was referred to replace number 11 due to external root resorption. And the endodontist felt that the source of the PA lesion was from 11. And so the endodontist is John Levin in Lafayette. And I said, John, you know, I don't see too many of these with periapical lesions. I said, I really think the problem's coming from here or maybe it's coming from this supernumerary tooth, or who knows. So, you know, the interesting thing is you do a scan, and right above number 10, this huge lesion, you got this going on. So it's like, well, obviously, this thing's got something to do with it. Here's where the resorption is. There's even some of the lesion there. So, you know, what we wound up doing is opening this area up, taking out the supernumerary tooth, apicoectomy, bone graft, temporize, bonded temporary. And then after 6 months, this implant right here. And in an area with a huge graft, this thing engages peripheral bones so well that we put this in, it's just as tight as a drum. And I wouldn't feel comfortable putting in a conventional machine threaded type root form implant in a graft like that. Here's another deal. This patient's referred to remove number 25, implant placement. Anybody see a problem? Looks pretty straightforward. I mean, it's an endodontic lesion, but this is the deal here. And it's like, look at that. I'm just going to take this tooth out. We're just going to put an implant in. And with a conventional X-ray, it certainly looks like you could. But look what's going on down here. Like I said, using this scan, same thing up here. You know, let's just lose this tooth. Look how thin this is. So you start seeing some things that you just don't see with conventional radiographs at all. Look at this one. This lady's 6'3". It's a black woman who came to see me for something. She's big. I mean, her face is big. It's almost as big as yours. I mean, it's a big old head. And look at this bone. I mean, look at that. And I told her, I said, man, you better take good care of your teeth, because if you lose them, you're going to be up a creek. You know, but without the scan, I have no way of even imagining that this is what this looked like underneath. Here's an ortho case, real talented orthodontist that practices in our town who graduated with us, said, I think he's the best. And I said, man, I saw one of your patients. His chief complaint is, I can feel the roots of my lower anteriors with my tongue. So he's the brother of one of my dental assistants. I said, well, let's take a scan and see what it looks like. And this is what we're dealing with. So I sent Oob a copy of this. He goes, it's no big deal. Don't worry about it. I said, okay. But, you know, when I see this, boy, it just makes me nervous about what's going to be the long-term prognosis for these teeth. And he's already getting lingual gum recession. There's another case, post-ortho consult. 12 is hopeless, 30 and 19 are missing. Like I said, we're going to take photographs on our patients because I want them to see what's going on. Her dentist had put her in provisionals, then they put her into braces. And these things came off 100 times. She was so mad, you know, the whole 9 yards. So they try to do ortho with just, instead of using laboratory process provisionals and put them on with a permanent cement, he made some, put them on with temp bond. We can't really move teeth with that as an anchor. But when we evaluate the case, and I'm showing her what's going on, I want her to see we have this going on down here. Okay? And I want her to see what a right lateral looks like, left lateral. But basically, we're going to show a patient a scan and where we're thinking about placing our implants. Ahead of time, we already know what diameter we think we're going to use, what length we think we're going to use, and the scan just gives us all of that information. And this is just before simulation of what her smile could look like after. And we do this on a lot of patients just to give an idea where we're headed. These are some AnyRidge implants that were placed, number 12, 30, and 19 sites. That was her case. And like I said, these things just grab that bone to the point that you feel like you could almost make your impression that day and make your final crowns then, which we don't do. But this is my good friend Mark that I hunt with a lot. He comes in one day, he's got a little toothache. We run a scan. He's got, he's got endo problems everywhere. 3, 14, okay, 19, and no idea, you know. And so before one of those teeth becomes a bridge abutment or gets a crown or something like that, I really want to find out if we've got something like that going on. Because when the tooth blows up, I don't want the endodontist to have to go drill a hole through the crown because we missed the diagnosis based on a periapical radiograph. Here we are down here, 19. Here's a lady with hopeless remaining lower dentition. She got Sjogren's syndrome, upper RPD, wants to consider maxillary posterior implants, fixed crown and bridge. Once again, go through the scan. Let's start looking at how much available bone is. This would be in the number 12 site. Looks nice and wide. All right. Place our implant. So we know that we're going to go ahead and be selecting a 13 millimeter length, 4.1 millimeter diameter. So, you know, if you order an implant, you can kind of figure out ahead of time what you need, and basically just go through the whole treatment plan using that scanner. In the mandible, you know, we're looking at where's the nerve, and this thing does a real nice job of identifying where the nerve is so that you can trace it out and show a patient what's available, and also determine what can be done and what can't be done. So these are just more slices. This is the case after it's finished. This is a patient of my buddy Chuck's, 54-year-old female, congenitally missing bicuspids, all 4 quadrants. She wants temporaries the same day. She wants this. She wants that. I mean, people's demands are just through the roof, it seems. So here we can look at the scan ahead of time and get an idea of what does a bone look like in these sites above these deciduous teeth. And you can see right here, we don't have a whole lot of height. Don't have a whole lot of height here. We do have a lot of width. And I like using AnyRidge implants in these sites, and I don't feel comfortable using anything else other than that because of the fact that it grabs that cortical bone so well that it's just a whole paradigm. It's just, I hate to use that word, it's just different from what we're seeing with conventional implants. So we're looking at these sites. Down here looks good. This is interesting here. Look at the difference in density here. We wind up using a real large diameter implant in this area to engage the cortices in this particular site. And we know right here we're going to be doing antral augmentation through the osteotomy at the same time that these implants are placed. So here we are at 6 weeks. You see we've done a sinus lift here, sinus lift here. These were placed at the same time. Okay. You see we used a large diameter implant on the lower left side, because this is where the this is where the bone. We're not very dense in here, and when you get in there, it feels just like this looks. I mean, there's just not much density there. So we're going to use something that's wider in diameter that engages the buccal and lingual cortices, and so we get better primary stabilization that way. In the lower right side, a tapered screw vent implant. As I said, we have one of these things in our office. It's called a Trios 3-shape scanner from CAD Blue. What it allows you to do is you can undo the healing collar, take this out, you put in a scanning abutment, you scan it, it produces this image, then the lab can go ahead and create a custom abutment on a model that's made from the CAD-CAM unit and produce a custom abutment. And in this case, we did it with impressions, but we'll address the digital scanning thing for the sake of the course. Like I said, I'm not real wild about it. I think it's going to get better. It's very pricey. But this is what I like, is getting this back from the lab where you can't, the soft tissue has been removed from these models, so you can't see where the gingiva is, but this margin is made to follow the free gingival margin just as it is in the mouth. So when I get these back from the lab, they also come back with temporaries made on them as well, and I mean real nice temporaries. So the day we deliver the case, we screw these custom abutments in, we torque them in, we put our temporaries on, then we refer the patient back to their dentist, or we take our final impressions that day. And now that we've been doing this, I just don't use stock abutments anymore at all. I find this saves a lot of time. It's a little bit more expensive, not a lot. What is a stock abutment? What does your stock abutment cost? $90. So these are $170. And then I have a temporary made for another $30 or something like that. And we can just take better impressions. I'll show you some more cases, and it'll become more apparent why I love these things so much. I don't know what that's all about. These are just showing some immediate cases with the sinus elevation. Another thing I like about the scan is being able to look and find out how much width we have in this area right here. This is a relatively recent extraction site. But boy, as soon as you pull the scan up and you see this going on, you know that you're going to have a width situation. So this is a case that could be done concomitantly with grafting, or perhaps in some cases the graft is done ahead of time. In this case, we grafted first, went back, and Dr. Domang placed the implant after. Some of these cases are cases from the course that we give in the office that I'll talk about later. But it's just showing a patient sort of graphically what we're thinking about doing, how much bone's available. We get a better idea ahead of time of our angulation issues, and it just really helps. You know, every morning before I go to work, sit down at my machine at home, I dial up the office, pull the scans up for all the patients we're going to be treating, and really kind of measure twice, cut once. Just some more examples of immediate placements. Let me run through the rest of this stuff. This here, we're looking at number 14 site. Get a good idea of how much bone height is available. Here we've done an antral elevation, immediate placement of the AnyRidge. You know, a lot of years ago, it's like, well, we got to augment this and then go back. These things grab that 3 or 4 millimeters of bone so well that rarely will we graft the site and then go back and do this later. We just do it at the same time. So let's escape out of there. And the spirit is moving me to talk about custom abutments.
We're going to switch out the LCD.
You want to do it at the break?
Yeah, that's the break.
Okay, good. Okay, good. Huh? Oh, we use mine. Okay. So, does anybody have any questions about anything? Yes, sir.
What technique do you use for subantral augmentation? Osteotonal or?
I use everything. If they're asleep, I like the hammer, but I also use motorized bone spreaders. You know what I'm talking about? Okay. And I also use the SCA kit from Zimmer. Blue Sky Bio has the same thing. It's a drill that they use in neurosurgery to go through the cranium, and when it's drilling, the particles go in front of the bit so that you wind up not perforate the meninges, or in our case, the antral membrane. And I've had good luck using those things. I really like them. You familiar with that too? Huh? Yeah. So which one is? You know, it's kind of like the safest thing to do is to use those burrs. I think I've had good luck with those, but every now and then, just out of habit, give me those osteotomes. Bang, you know, put some graft in there, maybe a collar plug, and tap it up, and and then just do it the old-fashioned way. But I also like using those motorized bone spreaders because the tips are dull, and I'll show that in a minute. You know, the tip of it is just like a dome, and that'll push it up as well, you know, with control force. Sometimes with the hammer, if you don't have a stop, you know, it goes where you don't want it. You can go into the orbit, I guess, hit it hard enough. This is, can you do that for me? Make it play. So this is a, there you go. This is, the concept is that we screw in an impression transfer, we take an impression, you know, then we unscrew this and we send it off to the lab, and they'll produce, in this case, a zirconium abutment with a titanium base, and then this thing goes into place, and it's anatomically, it's perfect. And I'll also, as I said before, then I'll have the lab make a custom abutment, a nice lab process provisional restoration to go on that same day. You know, and it's just like this. Instead of taking out a stock abutment, grinding on it, part of the margin supragingival, a bunch of it subgingival, and it just doesn't work as well. It's kind of the same thing on the bottom.